Welcome to the NUT webinar. My name is Laura Guerra, and I'm a special visiting assistant professor for the Masters in Public Health program at Hofstra, where I teach biostatistics and epidemiology. Thank you so much for the opportunity to share my research with you. As I go through the presentation, please feel free to submit your questions in writing, and I will take them at the end of the presentation. Even before the latest shooting, it was widely known that adolescent mental health is a critical public health issue. Data collected in 2010 indicate that 20% of all youth 13 to 18 years old have had a mental health condition. And research demonstrates that half of all lifetime mental health illnesses presents in the 14 to 15 range. Another study, more recent study, done in 2016, examining the trends in adolescent and young adult depression, indicate an upward trend in major depressive episodes. A major depressive episode is one where it greatly affects a young person's life. Poor adolescent mental health represents a potential barrier to learning. Adolescence is a critical period of developmentally, as youth are changing physically, biologically, and emotionally, as well as negotiating a key development task, that of getting increased independence. It's not unsurprising, therefore, that poor mental health is associated with increased risk behaviors. Now, among students with an individual education plan, those who are diagnosed with an ED, emotional disturbance, often are unilaterally removed by staff for drugs, weapons, and serious bodily injury. Of all of the different 13 categories on an IEP, 41 per 10,000 students are removed from the school. Also among the highest is the number of out-of-school suspensions or expulsions, with 407 per 10,000 children. 163 per 10,000 students receive in-school suspension, and 38% of students age 14 and over drop out of school. What's interesting, of course, is that this diagnosis of emotional disturbance is actually not based on any psychology examination, but rather an observation by the school professionals. Since adolescents spend the majority of their waking hours in schools, these institutions have increased potential to provide access to mental health services. The whole school, whole child, whole community model developed in 2013 out of the coordinated school health and the whole child models provides a framework to align the efforts of the education and health sectors. The model focuses on the child at the center and emphasizes a school-wide approach and stresses the alignment of policies and practices to support both health and learning. Indeed, the Office of Disease Prevention and Health Promotion has been documenting the nation's health improvement priorities for over 3 decades. And the newest one, Healthy People 2020, has a section specifically focused on adolescents and adolescents' health. Improving adolescent mental health addresses several of the goals defined by Healthy People 2020, including reductions in rates of attempted suicide, experienced major depressive episodes, and improved graduation rates. Now, of course, state and health education agencies provide resources to schools and to school districts to reinforce their efforts to support student mental health and learning. And the federal legislation, like the Every Student Succeed Act, has the potential to increase the state autonomy over education policy, as well as shift additional support and funding to schools and districts. These shifts may alter how schools approach student mental health. The problem is we cannot anticipate or evaluate the effect of state or school level changes on schools because we lack baseline measures of the whether any of these associative relationships exist. It really begs the question, what, if any, relationship these state and health agencies' efforts have on the policies and practices that are ultimately employed by schools? Specifically, what is the relationship between schools' self-reported implementation of mental health policies and practices and school and state level factors as reported in recent CDC datasets? What are the potential implications of legislation such as the Every Student Succeed Act for educators, researchers, and policymakers? Now, in actually looking at these questions, there was no single set of data that brought everything together. So it was necessary to bring together 3 specific data sets. The first, which many of us are very aware of, is the Youth Risk Behavior Survey, which asks young people in high school about their health risk behaviors, whether or not they wear their seatbelt and how often they drink or smoke or use drugs. There are also companion data sets, the School Health Policy and Practices Survey, which asks the lead person or the appropriate person within state health and education agencies what they are doing to address the same health risk behaviors and how they support the schools and districts. And then there's a specific survey, the School Health Profile Survey, which is broken down by area and sent to the school principal and the lead health educator. And that too also addresses or looks to address how the school principal and the lead health educator are supporting student health. To address these questions, I merged the 3 data sets and conducted an analysis. And you can see that the combined data set represented 4,670 schools in 22 states. As you would expect, I took a look at descriptive statistics to make sure that the data was normally distributed and look at and calculate and did all sorts of calculations to examine the data, looked at some correlation coefficients to quantify the strength and direction of the associative relationships. But ultimately, what we did was build a multi-level model to examine the relationship between outcome, that being school self-reported implementation of mental health policies and practices, and various school and state level predictors. Now, a couple words about multi-level modeling. Just for the layperson, they can be built top down, everything included, and then you eliminate those things that are not significant, or bottom up. Bottom up lends itself to simpler models, and of course our goal is always a parsimonious model. I used a total of 12 predictors were examined. There were 4 school level factors and 8 state level factors. Results from prior research would suggest that these factors are all related to the outcome, as they either support student health or actions meant to support health. But the literature does not, as we talked about earlier, provide any kind of quantitative measure between the relationship between the outcome and the factor. Now, which of these factors were significant? Actually, only those shown in orange. All of the school level factors that I examined were significant. So it makes sense, right? Using data when writing your school improvement plan. Of course, if you've got data, you're going to address the things that you see that have a deficit or where there's a problem. Presence of a health or safety coordinator, presence of a health council. And what was new, not found before, was that actually health educator certification to teach health education showed a strong positive association with whether or not schools implemented more or fewer health policies and practices related to mental health. Of all of the state level predictors, only one was significant, and that being health educator professional development. The study also indicated one significant cross-class interaction. This just simply means that there was a relationship between two of the factors that we looked at. One was whether or not the percentage of students who reported feeling sad or hopeless at school, and whether or not there was a health counsel in place. Now, when the way that it worked is when the two factors were both present, you saw that schools reported mental health policies and practices at twice the rate for every additional percentage point of depression reported by the students. So what kind of conclusions can we draw from this? Well, one, there's really limited evidence to suggest that the current state health and education agency efforts encourage increased implementation of mental health policies and practices. It could be that their efforts are too far removed from the schools themselves, but we don't know that. To meet ongoing primary and secondary prevention needs of adolescent mental health, schools require well-trained health educators. It's certainly an argument for the health education certified specialty credentials. School use of data when writing their school improvement plan, presence of health and safety coordinators, and the presence of health councils contribute to school environments that are very supportive of mental health. And certainly we definitely need more research on state-provided assistance and professional development, which may increase school support of mental health. Implications of the research are sort of interesting. What was one of the things that was sort of surprising was that there were actually almost half the sample of schools, or half the sample of states rather, had not done any evaluation of their mental health services in almost 2 years. So evaluations are required to ensure that states have the appropriate data to allocate resources and prioritize activities to support school efforts. School agencies should measure school readiness and capacity to support mental health. Schools need to ensure evidence-based practices and supports and make sure that supports are in place, including that they're using data, that they have well-trained, certified health educators, and the presence of health and safety coordinators and or health councils to support health and learning. Now, this research is being extended beyond mental health. And right now, I am working with some folks at Columbia to look at the same CDC data sets and then NIH's class data set to examine the relationships between state-level nutrition education policies and what policies and practices are being implemented in schools. The next slide shows some references I used in my presentation. And now I'm happy to take your questions. Okay, here we have one. Was there any finding in particular that surprised you? Actually, there was one that surprised me, and I sort of mentioned it or alluded to it earlier. That being the infrequency with which state and health education agencies seem to be doing any kind of evaluation of mental health services. In other words, what's the uptake of mental health services in the schools? Are people happy or satisfied with the services that they're getting? That really surprised me. I thought for sure that people would be at least doing basic satisfaction surveys. Here's another question. How might these findings be used to better support student mental health? Well, I think anybody who's working in the school system, certainly I do as an evaluation specialist, should make sure that we're disseminating best practices. It was very surprising to me a couple of weeks ago when I was in one of the most elite Upper East Side all-girls schools to find out that they had literally no data. They were interested in developing their health education program. They had all of these classes that they were teaching the girls, and yet they literally had no data about what the girls did or didn't do, and were using anecdotal information, mostly focused on the kids being stressed. That same school, surprisingly enough, did not have a health council. It had 3 gymnasiums, it had a 3D printer, it had resources that you couldn't even begin to comprehend, and yet there was no health council to address the student needs. So, of course, as educators, we should just all work in terms of disseminating like evidence-based findings. And that's it for our questions. Thank you so much for joining this webinar, and I hope that you'll come back and hear more from Hofstra.